Hello and welcome everyone. Today we'll be discussing about the extracorporeal techniques in ARDS. So ARDS is a syndrome where you have severe respiratory failure. So the extracorporeal life support, they provide a temporary support to give oxygenation to the body when the conventional ventilation is not sufficient to maintain the life, thereby reducing the risk of lung injury. So when our pressures are getting very high on ventilator and we are still unable to achieve our oxygenation or carbon dioxide removal, we have to resort to these therapies for help in ARDS. So ECLS is a general term which we use for either ECMO, that is extracorporeal membrane oxygenation, or extracorporeal carbon dioxide removal, ECOR. In use, particularly ECMO, has grown significantly after the 2009 H1 pandemic and the recent COVID pandemic. So we have two major trials which have been done in ARDS with the support of ECMO. The first was the CSER trial. It compared the conventional ventilatory support versus extracorporeal membrane oxygenation for severe acute respiratory failure. It was the pivotal study investigating the efficacy of ECMO in ARDS. It had 180 patients for severe ARDS. They were randomized to conventional versus ECMO. The significant reduction in composite outcome of death or severe disability at 6 months in the referral group was seen. 37% versus 53%. Referral to a specialty center adhering to the standard of care mechanical ventilation is always beneficial, though only 76% of the referred patient ultimately received ECMO. So you must understand that here the problem with this study was there was just one center. So in that center, most of the other centers were sending their patients. So 3/4 of the patients received ECMO. 1/4 did not receive ECMO because they probably either improved or they were too sick to be of getting any benefit out of ECMO. However, it does show that when your conventional ventilation is not good enough, you can do this therapy to save life. The next we had the EOLIA trial, which evaluated the VV ECMO in severe ARDS. They included 249 patients with PF ratio less than 80 for more than 6 hours. They were randomized to VV ECMO with ultra protective ventilation versus conventional management. The primary outcome of 60-day mortality did not find any significant difference, and 28% of the control group crossed over to ECMO, potentially diluting the survival signal, which means that control group also received ECMO. In the secondary outcomes, it suggested that patients in the ECMO group had a significantly more days free from renal failure and cardiac failure by day 60. Apart from that, there was a post hoc Bayesian analysis which showed that ECMO did have a mortality benefit also. So overall, again, stats apart, it is extremely clear that when your conventional ventilation is not working, you're clearly at a dead end. At that point, obviously, if you have a better therapy, it should be used. And in this case, it is the VV ECMO, which can be used to improve the oxygenation and improve the outcomes. Regarding the indications of VV ECMO, when should we use? ECMO is considered as a salvage therapy. Mind, it's not at all the primary therapy. The primary is still mechanical ventilation and the rest to the lungs. But when that is not achieved with conventional ventilation, we have to look for VV ECMO. So the first thing is severe hypoxemia. So despite your proning and ventilatory strategies, your PF ratio is still less than 80. And this is persisting for at least more than 6 hours. Or there is uncompensated hypercapnia, which means that though we are trying to tolerate the permissive hypercapnia, but still, despite all measures, we are unable to control the PCO2 and the pH is going less than 7.15. And I'm at this point, I have given my highest RR, I have given my highest tidal volumes, and my peak pressures are high. So I don't have any other way other than using extracorporeal therapy. Last but not the least, high plateau pressures. Same thing, in a different way is you have reached the limit of your ventilatory strategies. So you know that if you are going to increase your pressures higher, then you will be inducing ventilator-induced lung injury. So prior to ECMO initiation, adjunct therapies with proven benefits such as neuromuscular paralysis, proning, they should be considered and done and optimized. Don't just do it, you have to do it in the best way possible, and then you still have these problems persisting with you, then you go for a VV ECMO. So the indications are very, very clear. So what are the contraindications? There are some things where you cannot do. For example, if there is irreversible brain injury or some metastatic cancer, end stage lung disease with severe acute or chronic failures, where the recovery to the baseline is not possible at all. In that case, obviously this is not going to be therapy. And in this, if the patient is not planned for lung transplant, especially in a case of end stage lung disease, obviously there is no rationale of starting ECMO therapy. Next is prolonged high pressure ventilation. If you have maintained these high pressures for a long period of time, that is, patient is on very high FiO2 supports, very high plateau pressures for around say like 5 days, 7 days. So in those cases, it is very difficult to get any benefit because the damage is already done to the lungs and very difficult to get any benefit out of it. Regarding relative contraindications, ECMO may be considered in these cases, but you have to analyze the risk benefit because there is a risk associated with it and the benefit is going to be minimal. So do your analysis, try to find a risk benefit and then only apply for ECMO. Advanced stage, again, an old patient, how long that patient is going to live, you have to really think whether we should give such a high costly therapy with so much complications, with poor quality of life. What exactly are we trying to achieve? If you're still thinking that there is a benefit, then only go, because the risks in advanced stage are much more higher. Significant comorbidities, the patient already has a lot of comorbidities, then again the same thing, the quality of life is going to be hampered. Even if you may save the life with the ECMO, how is the patient ultimately going to survive with all these comorbidities and the added burden of the ICU stay and the ECMO that was happened? Patients who have high bleeding risk, because we are going to give anticoagulation, patients who are having a very high risk of bleeding, you have to really weigh your risk and benefit. And in cases of prolonged cardiopulmonary resuscitation, where obviously if the patient has a disease process which is irreversible or too long the CPR has been done, then probably just saving the life is more than what quality of life we are giving. So overall, relative contraindications, you have to check for the quality of life. See overall how the patient is. Am I able to improve his quality of life by giving this therapy, or I'm just doing it for the sake of doing? That is a very important thing that has to be analyzed, especially the risks of quality of life. Regarding cannulation and configuration, you have two types of configuration available, that is VV ECMO and the VA ECMO. You can have something called the veno-venous arterial, which is quite rare. Most of the time for the ARDS, we go for VV ECMO, where the drainage site is central vein and the reinfusion site is also central vein. It is essentially a respiratory support, and it is where we are doing ARDS. VA is when you have a hemodynamic problem as well. So for hemodynamic support, you are giving the arterial back. So that is a thing that you need to understand. Regarding the VV and VA, the drainage is central, but the reinfusion is split between artery and vein. The hemodynamic support as well as upper body oxygenation is achieved. It's a hybrid approach, can be used in ARDS presenting with severe cardiorespiratory compromise. Again, not a very common thing. It is mostly either VV or VA. The other place where we can use is the control of carbon dioxide. This was for oxygenation purposes. For control of carbon dioxide, the key determinants are the sweep gas flow when you are using for the CO2 removal. So it is the sweep gas which is the main determinant of the CO2 removal. The secondary factors are the PCO2 and the pH levels has to be titrated accordingly. Regarding the other factors, you have the membrane properties, the native gas exchange ability of the lung that is present, and the blood flow rates. They can affect it as well. But overall, as far as the carbon dioxide removal is concerned, it is the sweep gas, and sweep gas. So it is a sweep gas flow which will be deciding how much CO2 you are going to achieve. Regarding the VV cannulation approaches, choosing the appropriate cannulation for VV ECMO is crucial to optimize the oxygenation and the patient management. There are two primary methods, the dual and the single site. In dual, typically involves placing two separate cannulas, one for drainage, often in the femoral vein, and another at the infusion. The high risk of recirculation here is there. The other is single site approach, where you utilize a single dual-lumen vein. It can be inserted either internal jugular or femoral, but mostly in the internal jugular. These are specialized cannulas. The benefit is it minimizes recirculation because it has an optimized design, though it requires precise positioning, often requiring fluoroscopic guidance and transesophageal echo for optimal positioning of the cannula tip. Regarding oxygenation, the key determinants are extracorporeal blood flow, the flow rate to the circuit relative to the total cardiac output. The blood flow is largely limited by the cannula size. If the blood flow is more than 60% of the cardiac output, patient is often able to maintain a saturation of more than 90%. Next is the fraction of the delivered oxygen into the circuit. It is set by the blender. So the FTO2 through the circuit is again a determinant of oxygenation. Recirculation, it is the recirculation between the cannulas. It reduces the effectiveness of the gas exchange. Contribution is largely impaired in severe ARDS. And of course, you do have the native lung exchange also. So contribution is again impaired in severe ARDS. But you must keep in mind that it will show slow improvement. So gradually this has to be replaced by the FDO2. Regarding the ventilatory strategy, you do ventilate the lungs. It's not that we stop ventilating the lungs once we put on ECMO. So optimizing our ventilation strategy is very important. What is our main aim? Our main is to reduce villi, of course, because otherwise we could have increased the pressure high in the ventilator also, but that's we don't want. So the overarching objective of ECMO is ultimately to protect my native lung. So that has to be understood. It is not just oxygenation carbon, it is to protect my native lung. So I have to ventilate it in a way my lung is protected. So the ECMO provides crucial exchange support, allowing the clinician to go with ultra low tidal volumes and pressures. These strategies will reduce the stress and the strain on the native lung, thereby helping it to improve early. So ECMO is essentially allowing us time, allowing that lung to get some rest and heal without the stress and strain of ventilatory support. So in ultra protective ventilation, what we look for is the plateau pressure, where we target a plateau pressure of less than 25 centimeters of water. Reducing it to around 20 to 25 is suggested. The ultra protective ventilation aims for very low plateau pressures and often below the standard tidal volumes that we use in lung protective ventilation. PEEP again, less than 10 is optimal for us. In animal models, PEEP of 10 limited the lung injury and benefited gas exchange using ultra protective ventilation. So don't give too less, keep something around 10, not higher than 10 also. RR is again very important. RR is an important factor of your power and does cause lung injury. So keep it around 4 to 15, not less than 5 and not more than 15. Regarding the driving pressure, it has to be targeted to keep it less than 15. Dynamic driving pressure of less than 15 during the first 24 hours of ECMO initiation is one of the key factors associated with improved survival. Regarding anticoagulation, it is very, very important to understand that you have to balance your circuit's patency with the patient's safety. So it is a mandatory requirement to have systemic anticoagulation, which will have implications in terms of bleeding risk, but it is important to prevent the device failure. The primary agent is unfractionated heparin because its rapid action of onset and its reversibility most importantly. Therapeutic goal is to keep an APTT of around 40 to 60 or an anti-TNA activity of 0.2 to 0.1 international unit per ml. Though these are not actually some universal standards, every hospital has its own targets. The clinician must balance the significant risk of bleeding, which is around 40%, against the potential thrombotic event happening inside the device, causing the device to fail. So, risk benefit. Regarding the adjunct therapies, you can go for prone positioning, mobilization, extubation, and blood transfusion. These things can be done and should be done in ECMO to improve the outcomes wherever feasible. Don't try to overdo things, but obviously when it is feasible, do these things, especially proning, mobilization, transfusions. Extubation and awake ECMO is something we still need to understand. It is still controversial, but can be something tried in very select group of patients. Again, the select group, special populations who will require more understanding of ECMO. These are the obesity, the overweight and moderate obese patients often show better outcomes and lower mortality receiving ECMO. Obesity alone should generally not be a contraindication for ECMO. Immunocompromised patient, the use is limited. However, the overall 6-month survival is around 30%. Survival rates are lowest for patients with solid tumors. But again, risk benefit should be think, and the primary disease should be the determinant. The primary cancer, how bad it is, what is the chances of survival, that should determine our selection of ECMO, whether we should do or not. Regarding the pregnancy, survival outcomes tend to be more favorable for this group because these patients will definitely be young and should be treated with ECMO wherever feasible, though the physiology should be kept in mind. Regarding right ventricular injury, high prevalence in ARDS, around 20 to 50%. This is primarily driven by the pulmonary vascular resistance increase due to hypoxemia, hypercapnia and inflammatory mediators, leading to RV afterload increase and dysfunction. ECMO will mitigate the RV stress by reversing the severe hypoxemia and hypercapnia. These are major determinants of the PVR, that is pulmonary vascular resistance. Additionally, it facilitates the ultra-protective lung ventilation, further reducing the pulmonary pressures and the strain on the RV. So, RV does improve with ECMO. Regarding long-term outcomes, the survival rate is around 60% in the ELSO registry. While promising, this highlights the critical nature of ARDS and the ongoing post-ECMO care. Disability is very, very critical over here. That is why we have been discussing regarding the comorbid patients, old age patients. The survivors frequently experience significant physical, cognitive and psychological disability. These things have to be considered before initiation. And once you have initiated, active support must be provided for these things. So rehabilitation is critically important over here. A significant challenge arises when the patient cannot be weaned from ECMO and are not candidates from lung transplant. This is a very critical situation. The absence of durable destination therapy or portable extracorporeal devices makes it a very, very complex end of the life decision. This has to be done in a meeting with the relatives and the care providers. So it's an ethical dilemma. So I'm not going to the details of this, but it has to be considered before you are putting the patients on ventilator, especially those who are in end stage lung disease. Finally, the ECOR, the main objective over here is the CO2 removal. ECOR cannot give your oxygenation. It mainly helps only in CO2 removal. So it will remove the carbon dioxide and lower the blood using lower blood flow rates. Typically, it is less, around 200 to 1500 ml per minute, which is significantly less than that of ECMO, which is around 4 to 6 liters. This allows for precise control of CO2 level without fully supporting oxygenation. Now, the primary objective is to facilitate the ultra-protective ventilation, where my pressures are going very high. By removing the CO2, the ECOR enables the use of low tidal volumes and lowering the Prati pressure, thereby mitigating the VILI. Regarding ECOR, we have a lot of trials, the Supernova, the Extravent and the REST trial. The Supernova is a prospective trial in moderate ARDS. The outcome was to demonstrate feasibility of achieving ultra-protective tidal volume ventilation, and the conclusion was that it suggested potential reduction in the inflammatory markers. So by using this, they could reduce the VILI. In the Extravent, they gave a ultra-protective ventilation of 3 ml per kg with ECOR, and they found no difference in ventilator-free days overall, but it showed benefit in the post-hoc analysis with more severe disease. Regarding the rest, it was the ultra-protective with the ECOR plus standard low tidal volume ventilation. The trial was stopped early due to futility and safety concerns. Now, the ECOR is a viable therapy, but the point is the patient selection, the outcome that we are looking for have to be clearly weighed, and the risk benefit should be considered before we are initiating such therapy. The current guidelines recommend against ECOR in routine ARDS care outside of research setting. So, if you are not doing a clinical trial, do not do ECOR as of now if the setting is ARDS. Regarding the clinical research insights and future directions, the ECMO guideline development is still being done. The animal models are still being researched, which are crucial for ECMO evaluation, offering insight into the optimal ventilation strategy and host response. And while we have a lot of models like pig, sheep models are still prevalent, accounting for around 32 of the total studies. This is a growing trend towards using rat models to expand the research capabilities, because getting these large animals is more difficult. Getting to study on rats is more feasible. So let's see what happens in the future regarding the animal models. Regarding the research gap, the etiology is important. ARDS is just a syndrome, but it can be because of various causes. So often the background is missed. So only one study is used, a primary bacterial challenge, and more used in the viral challenge. So we have to look which type of etiology is affecting our outcome in ECMO. Regarding ECMO duration, again it is variable. Duration often ranges from days to even weeks. The most frequent duration is 24 hours, only 2 investigated thrombotic and thrombosis parameters comparing. Longer periods are needed to simulate clinical exposure. Regarding ECMO usage, ECMO use involves intense monitoring. Only 2 controlled trials are there. Further studies needed to understand how we should monitor our patients. So clinical research, we have gaps in terms of etiological impact on ECMO, the duration of ECMO that we need to give, and how we should monitor. These are not at all very well studied. So in our conclusion, VV ECMO is increasingly accepted as a reasonable salvage therapy for severe ARDS, maximizing the lung protective ventilation. However, continuous advances is required. Refining the indication is very, very important, based even on the etiology, and to find out which patient will benefit from VV ECMO. Optimize the timing. When should we start it? How long should we give it? Improving the ventilatory strategies. What strategy we should give? What should be our tidal volume? What should be our peak pressures? What should be our PEEP? These have to be studied. Personalizing the approach. The ECMO strategy should be individualized, and response to treatment and the complications should be done that way. Regarding the RCTs, we need to conduct robust RCTs to solidify the evidence base for the extracorporeal technology. Thank you for